Hello all, I will speaking here how to interpret an antibiogram. In the previous four sessions, we have seen how to interpret culture and status report. So using the learnings of the same previous four sessions, we'll learn here how to interpret an antibiogram, and we will conclude with few significant points related to interpretation of microbiology reports. Now, what is an antibiogram? Antibiogram is an overall profile of the sensitivity pattern or susceptibility pattern of different organisms against different antibiotics across different clinical settings of the hospital. This profile is generated by laboratory using data from the hospital. Now, what is the data? This data is from the testings of the patient's clinical samples, and this data is summarized periodically and presented showing percentage of the organisms that are susceptible to a particular antimicrobial. So, such antibiogram generated from this data should be prepared at least annually. It should be prepared separately for outpatient department and inpatient department. This should be generated separately for high-risk areas like OT, cath lab, dialysis, casualty, and other such high-risk departments. What is the use of this antibiogram? Antibiogram helps in formulating the antibiotic policy. It helps in guiding the clinicians and the clinical pharmacists in selecting the rational best empirical antibiotic while waiting for the culture and sensitive results. Antibiograms help the stakeholders for empirical antibiotics. It is a very useful tool for detecting and monitoring the trends of antimicrobial resistance. So that was about the importance of antibiogram. Let's see how to prepare an antibiogram. Let us first understand the basics of the different sensitivity pattern of different antibiotics against the different groups of organisms. For example, if you see the anaerobes, against anaerobes, clindamycin, metronidazole are active along with other antibiotics like coamexiclov, piperazine, tazobactam, ticagrelor, clanate, and others. Some of the antibiotics like meropenem, impenem are active against anaerobes, gram-negative bacilli, as also sensitive, as also they are sensitive against methicillin, sensitive to Staph aureus and Streptococcus. While some organisms are limited to only Streptococcus like penicillin, while some antibiotics are active against MRSA, that is methicillin-resistant Staph aureus, Streptococcus, and others. But they don't have any activity against gram-negative bacilli. So this is an antibiotic sensitive overview of different antibiotics against different groups of organisms. So it is important to understand this sensitivity overview before we proceed to the antibiogram. The most important thing is know your know your local antibiogram, the antibiogram of the local healthcare setting of the of the particular geographical area, and then antibiogram. This is how the antibiogram looks like. We have different sensitivity pattern of different of particular organisms against different groups of antibiotics. We get to know the frequency of isolation of different organisms against different from different clinical samples, and we get to know the sensitive pattern of the organisms against different antibiotics. So, how to prepare an antibiogram? We had first refer to this CLSI guideline, that is Clinical and Laboratory Standard Institute's M39A4 document. This is a present. It guides on how to analyze and present a cumulative antibiogram susceptible test data. What are the few important recommendations of this CLSI? Analyze the antibiogram at least annually, as said before. Include only the final results, not provisional results. At least more than 30 isolates sensitive results should be used for preparing antibiogram. Environmental results should be excluded. Eliminate the duplicates. Only to use the first sensitive result. And only those drugs which are routinely tested should be used for preparing antibiogram. Only susceptible results should be used, not intermediate. That was a different recommendations. If you can also we can also refer to use the WhoNet, which is an automated based EHR based antibiogram to prepare an antibiogram, wherein we have to enter the data and we get an automated antibiogram on a periodical basis. So antibiogram should avoid any misleading data. It should show it should have a statistical significance. Should include at least 30 isolates. First isolates should be considered. Final results and the compilation of these results should be done at least annually to prepare an antibiogram. And it should be the changing empirical therapy policy should be done. Empirical therapy should be changed following any changes in the antibiogram accordingly. What are the steps of preparing an antibiogram? First, compile all the local hospital data based on the sites of infection from different clinical areas like ICU wards and others. See the distribution of organisms across different departments. See the susceptibility of the antibiotics against different organisms. For example, put the data in a given template. I will share the template in next slide. So see the site of infection, enter the site of infection, the type of infection, the causative organisms. Preferably, is 6 month data is required, or at least 12 months, or 12 months. Capture pathogens contributing to 80 to 90% of the infections. Means the most commonly isolated organisms causing infections should be included in the antibiogram. And capture the susceptibility of antimicrobials from highest to lowest. The highest antimicrobial, the high sensitivity of antimicrobial, the highest sensitivity should be used uh, prepare the antibiogram. This is the template. It's a very friendly toolkit to put the data. This will be separate for ward and ICU. Most 5 commonest pathogens should be used, and most of the commonest five antibiotics with the most susceptibility should be used for preparing the antibiogram. So most common pathogens, their percentage prevalence, and the most sensitive antibiotics in the decreasing order. So get these two tables and then proceed. Identify the most common pathogens, like we can see from this chart, which shows about the efficacy of isolation of different organisms. So identify the most 5 commonest pathogens. Then identify the most 5 sensitive antibiotics, like you can see from this chart. The most five sensitive antibiotics should be selected, like peptide, imipenem, ertapenem, cefurum, sulfatem, cetirizine. So this 5 sensitive antibiotics should be selected. The 5 commonest organisms should be selected, and the data should be entered into the data. And this is how then the template looks like: the 5 commonest organism, the 5 commonest antibiotics with sensitivity, and the cutoff value. Now, what should be the cutoff value for selection of this antibiotic from the antibiogram? The cutoff value should be 80% for empirical therapy. So the antibiotic showing 80% sensitivity should be considered for this. In the same way, antibiograms can be made. Antibiograms can be made for different clinical samples like blood sample, urine sample, wound swab, up for different clinical departments like ward and ICU and others. So this is just an example of an antibiotic, how the antibiogram looks. The different antibiotic sensitivity against the different organisms and in decreasing order of the sensitivity. So this gives an idea to the clinicians for choosing the correct rational antimicrobial while for on empirical basis. So that was all about the antibiogram, and we have seen in the previous 4 sessions too how to interpret the sensitive results. So identifying the critical alerts is very important. Identify the critical alerts and communicating to the stakeholders is very important. So that, for example, say if we isolate a MRSA, that is medicine resistant staph aureus, which is a highly lethal pathogen, to prevent the spread of these organisms across the healthcare setting, and to have immediate rational treatment for the patient, it is important to identify this critical alert and immediately inform to the clinicians. Similarly, it is for the ESBLs and the carbapenem resistant Enterobacteriaceae. Growth of significant pathogen in any culture like Pseudomonas or asymptomatic, any, especially from fluid samples or blood sample, should be notified, should be informed, communicated to the clinicians. Now, what are the guidelines for the decision based on microbiology results? In any case, the results of sensitive testing needs to be interpreted with some background knowledge of the organism. As we seen in the previous session, the habitat of the organisms, the patient's history, the pharmacodynamics and pharmacokinetics should be considered while interpreting the results of sensitive reports. Do not use the antimicrobials if they are not necessary. Always take into account the natural resistance or the intrinsic resistance, and check for any unusual results. For example, if Staphylococcus is reported as vancomycin, it is very unusual to have vancomycin resistance against Staphylococcus or Streptococcus. So confirm it, check for such unusual results, and before we proceed for a treatment. Patient history is very important. Underline, we have seen a number of case studies in the previous sessions. The patient history is important. Underlying disease and previous treatment attempted are of utmost importance. Drug choice needs to take into account the drug properties, the pharmacodynamics, and dose adjustments should be made accordingly. Whenever possible, use the narrow spectrum antibiotic and reserve the most important drugs like colistin, tigecycline, and others for use in exceptional cases. So what's the take-home message? There can be infection without culture positivity, or culture positivity can occur without infection also in case of colonization and contamination. So this needs to be noted. Never treat a lab report. It's an in vitro testing. So treat only the objectively defined infection. Never treat a normal flora or commensal flora of body surfaces or unsterile surfaces. Colonization can also occur. So never treat the normal flora or colonization or contamination. Then choose the correct test. Choose the correct, have a correct interpretation of the test. Rapidly communicate to the stakeholders. An appropriate adjustment of the antimicrobial regimen should be used based on the diagnostic test results. These are the key. These parameters are the key to optimize antimicrobial prescribing. Then point of care test or rapid test, early identification, and it enables an early identification and initiation of therapy. But a negative point of care test or rapid test does not mean absence of disease. So positive test may be false positive too. So biomarker. The another thing is biomarkers. They are good as a rule of test, but they have a high negative predictive value, but they cannot be used for guiding initiation of antibiotics. So that was all about the take-home messages we have seen in this pack of 5 sessions. How to interpret the sensitivity results and make the best use of the sensitive results for the patient treatment. Thanks all of you for your kind attention and cooperation. Thanks a lot.